Osteochondral lesions, also in juvenile type osteochondritis dissecans, can happen due to trauma or AVN. Best prognosis is that the physis is open. Location is posterolateral aspect of lateral femoral condyle. It has poor prognosis. Most common site is posterolateral aspect of medial femoral condyle. So medial femoral condyle is the common area, posterolateral aspect. If happens in lateral femoral condyle, has poor prognosis. Initially soft tissue cartilage injury, and then detachment and creating into a loose body. Classification is Clanton and D. Lee. Number 1 is partial depressed lesion. Number 2 is partial detached. Number 3 is detached, non-displaced. Number 4 is displaced. A tunnel notch view, knee bent to 30 to 50 degrees to assess for the lesion. MRI, synovial fluid behind the lesion. Management, undisplaced, restricted weight bearing, subchondral drilling with K-wire or drills. Less than 12 years, good prognosis. Unstable, detached, if fragment more than 2 cm, fixation is needed. Herbert screw, cannulated screw, chondral dart, or expanding subchondral drilling. For adult form, outer bridge classification, 0 is normal, 1 is softening, number 3 is fissure or fibrillation, partial, number 3 is full thickness, fissure or subchondral bone fracture, number 4 is exposed subchondral bone. Management, correct the malalignment and ligamentous instability, debridement chondroplasty if the damage is less than 1.5 centimeter, excision, unstable cartilage fragment with radio frequency ablator, roughening of some chondral bone encourages a fibrocartilage. Fixation can be by smart pin / smart nail, by absorbable fixation pin made of polyl-lactic acid. Microfracture technique if lesion is less than 4 cm, done by the chondral pick. Punctate perforation deep to the subchondral bone, depth 5 mm until you see subchondral fat globules. Post-op CPM and non-weight bearing for 6 weeks. CPM allows the movement of synovial fluid. Mosaicplasty, OATS, osteoarticular autograft transplantation, non-weight bearing lesion of less than 4 cm is taken and placed over there. Socket drilled at the site of the defect and plugged by a press fit. Autologous chondral site implantation. It is basically in 2 stages. In stage 1, a graft is harvested from the non-weight bearing area, and stage 2, after 2 to 3 weeks, a defect prepared and chondrocytes which are cultivated in the lab are injected under a periosteal patch. Another option is matrix autologous chondrocyte implantation. It is a collagen scaffold. It avoids the problem with the periosteal flaps. NICE guidelines states that uncertain about the long-term results of these interventions. Partial weight bearing advice for 12 weeks. NICE guidelines state that ACI is recommended for treating symptomatic articular defects if there is no previous surgery for repair cartilaginous defects, minimal osteoarthritis, defect more than 2 cm, and done at tertiary care referral center.